All right, well, again, thank you so much for having me. I'm very excited to be here speaking today about reproductive coercion and its impact on reproductive health. As Caitlin mentioned, I'm one of the co-authors of Exposing Reproductive Coercion, which is a toolkit for awareness raising, assessment, and intervention. I believe everyone was provided with a PDF of the toolkit who signed up for today's talk. I encourage you to look through it after this talk. It's got a lot of great information on it. It has fact sheets for awareness raising. It has a wonderful self-quiz, and it has assessment and intervention tools for both reproductive health care practitioners and domestic violence advocates. This toolkit was a collaboration between three nonprofit organizations, the Feminist Women's Health Center here in Atlanta, Georgia, and two national domestic violence organizations, the National Coalition Against Domestic Violence and the National Organization for Men Against Sexism. And all three of these organizations are very committed to raising awareness around the issue of reproductive coercion. A little bit about my background before we begin. I did my undergraduate work at the University of Southern California, Fight on Trojans, where I double majored in health and humanity and gender studies, and that's really where I became interested in issues related to women's health. I decided to do my graduate work at Emory University, where I've been studying the behavioral aspects of reproductive health. I'm particularly interested in contraceptive use and non-use amongst adolescents. And I've also been working for the last 2 years as a consultant to the Feminist Women's Health Center here in Atlanta, which is a nonprofit reproductive health clinic that provides comprehensive reproductive health services to the women of Atlanta and beyond. I've done several projects for Feminist Women's Health Center, including the Reproductive Coercion Toolkit I mentioned, and more recently I've been assisting with the development of their Black Women's Wellness Program aimed at addressing health discrepancies in Atlanta amongst minorities. So today's talk is going to be split into 5 sections. We're going to start by asking the question, what is reproductive coercion? What are we talking about today? What is this phenomenon? 2, what is the link between reproductive coercion and intimate partner violence, or IPV? 3, assessment. How do we assess for reproductive coercion in a clinical setting? And moving swiftly into 4, after we've assessed for reproductive coercion, how do we intervene successfully in cases where we suspect reproductive coercion? And finally, 5, I'm hoping to leave time for discussion and questions at the end of this talk. I think we should have at least 15 minutes at the end for discussion and questions. Moving right into it, reproductive coercion. What is reproductive coercion? Reproductive coercion is the behavior used to pressure or coerce a woman into becoming pregnant or into continuing or ending a pregnancy against her will through the use of manipulation, intimidation, threats, and/or actual acts of violence. Reproductive coercion is a form of intimate partner violence, also known as domestic violence. Reproductive coercion most often manifests within the context of an intimate heterosexual relationship when a man uses pregnancy-controlling behaviors in an effort to maintain power, control, and domination over a woman. I'll return to those 2 asterisks on my next slide. An example of this would be a man trying to get his girlfriend pregnant against her will in order to keep her physically and financially tied to him forever. And finally, and very importantly, women victimized by reproductive coercion may not recognize that these behaviors are abusive, particularly if there is no history of physical or sexual violence in their relationship. So back to those 2 asterisks I mentioned, I have 2 important disclaimers before we move on. 1, the language of this talk reflects the fact that reproductive coercion most often manifests within the context of an intimate heterosexual relationship, and the fact that women are more likely to be the targets of domestic violence than are men. However, reproductive coercion can occur within the context of LGBTQ relationships and within the context of non-sexual relationships, e.g. parent-child relationships. So this, for example, would be a case where you have a parent who is trying to pressure or coerce their pregnant teenage daughter into continuing or ending a pregnancy against her will. All right, moving on. Reproductive coercion is a somewhat poorly understood phenomenon. It's related to domestic violence, and it certainly has impacts on reproductive health. However, it's not fully understood by individuals working in either of these two fields, and we feel that that is likely because there has historically been a divide between individuals working in these two areas. However, reproductive coercion is an issue that really sits directly between issues of reproductive health and issues of domestic violence. And for that reason, we feel it's very important for individuals working both in reproductive health care and as domestic violence advocates to have an awareness and understanding about reproductive coercion so that they can assess for reproductive coercion and intervene in cases of reproductive coercion in their work. Okay, so what does reproductive coercion look like? Reproductive coercion can manifest in several forms. However, the three most common are pregnancy pressure, birth control sabotage, and pregnancy outcome control. It's also important to mention that these forms of reproductive coercion occur at different time points. So pregnancy pressure, for example, happens prior to conception. Birth control sabotage, on the other hand, can happen prior to conception, and it can also occur during acts of sexual intercourse. Pregnancy outcome control is going to happen after conception. So whether a woman is pregnant or not, she is still susceptible to reproductive coercion. And I'm going to break down each of these forms of reproductive coercion in more detail. So what is pregnancy pressure? Pregnancy pressure occurs when an individual pressures or coerces a woman into becoming pregnant against her will. Examples of pregnancy pressure include hurting a woman or threatening to hurt a woman physically, economically, or emotionally if she refuses to become pregnant. Making a woman feel guilty for not wanting to become pregnant. And accusing a woman of infidelity if she does not want to become pregnant. Anecdotally, I can report that the most common form of pregnancy pressure we hear at the Feminist Women's Health Center is actually this third example of women saying that their partners are accusing them of being unfaithful because they do not want to get pregnant. Birth control sabotage. Birth control sabotage, as it sounds, occurs when an individual interferes with a woman's use of contraception to cause her to become pregnant against her will. Examples of birth control sabotage, and they are varied, include refusing to pull out when previously agreed upon, pulling off contraceptive patches, pulling out vaginal rings, hiding, tampering with, or destroying birth control pills. Again, anecdotally, a common story we hear is flushing birth control pills down the toilet, refusing to use condoms, breaking condoms during sex, pulling condoms off during sex, poking holes in condoms. Condom sabotage is, again, very commonly reported by our patients. And finally, physically or economically preventing a woman from obtaining contraception. Pregnancy outcome control. Pregnancy outcome control occurs when an individual pressures or coerces a woman into continuing or ending a pregnancy against her will. Examples include making a woman feel guilty for wanting to continue a pregnancy or have an abortion, convincing a woman that she has no other option but to continue a pregnancy or have an abortion, or hurting a woman or threatening to hurt a woman physically, economically, or emotionally if she continues a pregnancy or has an abortion, and finally, physically assaulting a woman in an attempt to induce a miscarriage. Reproductive coercion is not a small issue. An estimated 10.3 million women in the United States report having or having had an intimate partner who had attempted to get them pregnant against their will, or who had refused to use a condom. So moving on to reproductive coercion and intimate partner violence, the link between these two phenomena. Well, a growing body of research is providing evidence for a connection between intimate partner violence and less obvious forms of coercion, such as reproductive coercion, that have major implications for reproductive and sexual health. I think most of us have heard the statistic that 1 in 4 women will be victimized by intimate partner violence at some point in her life. And we know that intimate partner violence is associated with an increased risk for a number of poor reproductive health outcomes. For example, women who are being abused by their intimate partners are at increased risk for unintended pregnancy, sexually transmitted infections, women not being able to use their preferred contraceptive method, miscarriage, repeat abortions, and poor pregnancy outcomes. And just to highlight the strength of this association, when intimate partner violence is present in a relationship, a woman's risk of unintended pregnancy actually doubles. But why should this be the case? Why should women who are in abusive relationships be at increased risk for unintended pregnancy and sexually transmitted infections? We feel that the link between IPV and poor reproductive health may be reproductive coercion, because 25% of women who report being physically or sexually abused by their intimate partners also report being pressured or forced to become pregnant. So you can think of reproductive coercion potentially as the missing link between intimate partner violence and poor reproductive health, including increased risk of unintended pregnancy and increased risk of sexually transmitted infections. There is also reason to believe that intimate partner violence and reproductive coercion may particularly impact adolescent health, or that adolescents may be at increased risk of experiencing intimate partner violence and reproductive coercion than adult women. For example, we know that non-fatal intimate partner violence peaks during late adolescence. So adolescent girls are more likely to experience non-fatal intimate partner violence than are adult women. We know that adolescent females victimized by intimate partner violence are more likely to engage in risky sexual behaviors. These include early onset of sexual activity, so before age 15, condom non-use, and having multiple sexual partners. In one study of adolescent females victimized by intimate partner violence, more than 26% of participants reported that their abusive male partners were actively trying to get them pregnant. So we know that this connection between intimate partner violence and reproductive coercion is occurring in adolescent relationships as well as adult relationships. We also know that up to 2/3 of teen pregnancies occur within the context of an abusive relationship. And finally, adolescent females victimized by reproductive coercion may be less likely than adult women to recognize that these behaviors are abusive. So for all of these reasons, we feel that adolescent girls may be at particular risk for reproductive coercion and the negative pregnancy outcomes or negative reproductive health outcomes associated with it. There's also anecdotal evidence to support that adolescent females are experiencing reproductive coercion. I've selected a few quotes to share with you that I feel encapsulate this issue, but I could have chosen from many, many more. So for example, here's one quote. He was like, "I should just get you pregnant and have a baby with you so that I know you will be in my life forever." And that was from a 19-year-old girl. "He used condoms when we first started, and then he would fight with me over it, and he would just stop using condoms completely and didn't care." From a 16-year-old girl. And finally, "I was on the birth control pill and I was still taking it, and he ended up getting mad and flushing it down the toilet, so I ended up getting pregnant. I found out that before this, he talked to my friends and he told them that we were starting a family. I didn't know that. I didn't want to start a family. I wanted to finish school." And that's from a 17-year-old girl. So assessing for reproductive coercion. How do we assess for reproductive coercion in a clinical setting? Well, there are several pre-assessment considerations that should be taken into account. And these are all in the effort to facilitate full disclosure on the part of your patient. First, it's important to make educational materials about reproductive coercion and intimate partner violence available that are reflective of the constituency you serve. We really believe in making these materials available in multiple places throughout your facility. For example, in waiting rooms and in exam rooms and in bathrooms. We have actually found that materials on intimate partner violence disappear from our ladies' restrooms faster than they disappear from anywhere else in our clinic. And we feel that this may reflect the fact that women are choosing to collect these materials in a place where their intimate partner cannot follow them. And perhaps he's sitting next to them in the waiting room and she doesn't feel comfortable taking these materials out there. Second, have signage in all waiting areas announcing that as part of clinic policy, all patients must speak with a clinician in private for at least a portion of their visit. This ensures that you'll have an opportunity to discuss these sensitive issues like reproductive coercion and intimate partner violence without her intimate partner being present. And establish a private place where patients can be interviewed alone and where conversations cannot be overheard or interrupted, again, in an effort to encourage full disclosure. Importantly, always disclose the limits of confidentiality prior to assessment. And remember that the laws surrounding the limits of confidentiality may vary for minors versus adults. Establish a clear protocol of how staff should proceed if they feel a patient is being victimized by reproductive coercion. And this is important because it can facilitate the transition from assessment to intervention. I would really like to emphasize the importance of both written and verbal assessment. Questions that broadly address various forms of reproductive coercion should be included on the self-administered questionnaire that a patient fills out at the beginning of their visit. And answers on the written questionnaire can then be used to initiate a conversation about reproductive coercion in private during the patient's visit. However, regardless of a patient's answers on their written assessment, clinicians should incorporate questions about reproductive coercion into the verbal assessment they conduct in private during a patient's visit. Again, this is related to the fact that when she fills out her written questionnaire in the waiting room, her intimate partner may be sitting right next to her, and she may not be able to fully disclose her experiences. So, potential assessment questions. I just chose a few potential assessment questions to share with you. There are many more in the toolkit, and I encourage you to go and look at them if you're looking for more ideas for potential assessment questions. It's important to have assessment questions that address various forms of reproductive coercion, so I chose a few from each category. Pregnancy pressure. Has your partner ever made comments, even jokingly, about getting you pregnant against your will? Has your partner ever pressured you to get pregnant when you didn't want to? Has your partner ever yelled at you, put you down, or threatened to leave you because you didn't want to get pregnant? Birth control sabotage. Have you ever had to hide your birth control from your partner? Has your partner ever tampered with your birth control, thrown away your pills, or pulled out your ring? Has your partner ever refused to use a condom when you asked him to? Has your partner ever refused to pull out during sex, even though he said he would? Do condoms seem to break a lot during sex? And this is actually a question that we've had a lot of success with in assessing for reproductive coercion. It turns out that if a man is purposefully breaking condoms during sex, his female partner is likely to be unaware of what he's doing, and she may think that condoms are breaking of their own accord every single time she and her partner have sex. So this question can be very useful in assessing for reproductive coercion in cases where women really are fully unaware that the behavior is even happening. Pregnancy outcome control. Do you and your partner agree on what you should do about your pregnancy? Continue the pregnancy or have an abortion? Is your partner pressuring you to do what he wants you to do with your pregnancy, even though it's not what you want? And are you worried about what your partner will do if you do not do what he wants with your pregnancy? Again, these are just some potential assessment questions, and there are many more in the toolkit if you're looking for other ideas. So the manner in which you initiate a conversation about reproductive coercion with your patient is going to vary depending on the services she's at your clinic to receive. For example, If a patient is seeking birth control, you might initiate a conversation about reproductive coercion somewhere along the lines of, because it happens so often, we've started talking to all of our patients about birth control sabotage. Is your partner okay with you using birth control? Has your partner ever tampered with your birth control? But if a patient is already pregnant, the conversation is going to be different and may go along the lines of, a lot of times partners disagree about how to deal with an unintended pregnancy. Does your partner have a strong opinion about what you should do with your pregnancy? Are you worried that your partner will be angry if you do not do what he wants with your pregnancy? Moving right into intervention, how do we intervene when we suspect reproductive coercion? Before we move into intervention techniques, I want to share with you the results of Miller et al., which was a study published in Contraception in 2011. And this study examined the efficacy of a family planning, clinic-based reproductive coercion intervention strategy. This study was done with 4 freestanding urban family planning clinics in Northern California. 2 of the clinics were randomly assigned to implement this new reproductive coercion intervention strategy, and the other 2 did not implement this strategy. They had a large sample size of women who participated in the study. These women were English-speaking and Spanish-speaking women between the ages of 16 and 29. And the intervention strategy they employed focused on awareness raising and provided harm-reducing strategies. So what did they find? They implemented this intervention strategy, and then they did a follow-up with women who participated in the study 3 months later. What they found was that among women who had recently been exposed to intimate partner violence, they were able to decrease the occurrence of pregnancy coercion by 71% using this intervention strategy. They also found that women who had undergone the intervention strategy versus controls were more likely to end a relationship because they felt unhealthy or because they felt unsafe in their relationship. And the reason I share these results with you is just to emphasize that we know that reproductive coercion intervention strategies can work and they can make a difference. They can decrease the incidence of pregnancy coercion, and they can encourage women to examine their own relationships and choose to leave a partner that they feel is abusive. So moving on to intervention strategies. Any reproductive coercion intervention strategy is going to have 3 important steps. Step 1 is going to be address the quality of her relationship. Step 2 is going to be help her take control of her own fertility. And 3, very importantly, is going to be help ensure her physical safety. And we're going to go through each of these steps in more detail. So step 1, address the quality of her relationship. If you feel that a patient is being victimized by reproductive coercion, we recommend first expressing your concern for what she is going through and letting her know that she's not alone, that this is an issue that affects a lot of women and that she is not in some way unique, that this is happening to her. Introduce the concept of reproductive coercion and provide her with informational materials about reproductive coercion. We also recommend offering to go over the materials with her. Very importantly, validate her rights and wishes within her relationship. E.g., she has the right to not want a child with her partner. And finally, initiate a conversation about ways she can help take control of her own fertility. However, again, it's important to remember that women victimized by reproductive coercion may not recognize that these behaviors are abusive, particularly if there is no history of physical or sexual violence in their relationships. So step 2, what do I mean by help her take control of her fertility? Well, again, this is going to depend on your patient's unique situation. But in general, if she does not want to become pregnant, we would recommend discussing the potential benefits of concealable contraceptives. And what I mean by concealable contraceptives are contraceptive methods that her partner is not going to be able to see, feel, or tamper with. And in general, this means the LARC methods, the long-acting reversible contraceptives, the implant, Nexplanon or Implanon, the injection, Depo-Provera, and one of the IUDs, Mirena, Skyla, or Paragard. As an important safety tip, you can mention to her that the strings of an IUD can be cut so that her partner will not be able to feel them. If she's recently engaged in unprotected sex and does not want to become pregnant, of course the conversation is going to shift to emergency contraception. And when people hear emergency contraception, I think their mind immediately goes to the morning after pill, Plan B. However, the Paragard IUD, which is the copper IUD, can also act as an emergency contraception if it's inserted within 1 week of unprotected sex. The benefit of the IUD, of course, being that it will then go on to continue protecting against pregnancy for up to 10 years. So the Paragard IUD can be a good option for a woman who has recently engaged in unprotected sex and is concerned that her partner may continue to try to get her pregnant in the future against her will. As another safety tip, if she is going with the morning after pill, suggest that she take the pill while she is still at the clinic, or send the pill home with her in an unmarked envelope. This will circumvent her partner finding the pill packaging materials in the trash can. So let's say she's already pregnant and she does not want to continue the pregnancy. Well, of course, the situation was going to shift, and instead you're going to want to provide her with information on where she can obtain a safe, legal, and confidential abortion. Safety tip, again, allow her to use your clinic's phone if possible, or suggest that she use a friend's phone or a pay phone to call and make an appointment for an abortion. This is, of course, if there's a risk of her partner checking her recent calls on her cell phone. If she's pregnant and she wants to continue the pregnancy, discuss the importance of prenatal care for better pregnancy outcomes. If your facility does not provide prenatal care, refer her to a prenatal care provider in your area. And if she's considering adoption, provide her with information on adoption and refer her to adoption services in your area. Step 3, help ensure her physical safety. Clinical staff should follow up any disclosure of reproductive coercion with questions to screen for other forms of intimate partner violence. If she is concerned about her physical safety, or she admits to you that her partner has physically abused her in the past, provide her with the contact information for local organizations that provide resources for individuals victimized by domestic violence. If no local resources are available, refer her to an advocate from the multilingual National Domestic Violence Hotline. Same safety tip as before. Allow her to use your clinic's phone if possible, or suggest that she use a friend's phone or a pay phone to call a domestic violence organization or hotline, again, if there's a risk that her intimate partner is going to check her recent calls on her cell phone. If she's experiencing abuse that you are obligated to report to the state, explain the reporting process and involve her in the writing of the report. So this is a sample script that we've written for intervening in cases of reproductive coercion. From what you've told me, it sounds like your partner may be trying to get you pregnant even though you've told him you don't want a baby right now. Thank you for sharing this information with me. This happens to a lot of women, and I know it must be very stressful worrying that you're going to get pregnant. Your partner's behavior sounds like reproductive coercion. Reproductive coercion is a form of intimate partner violence where a man pressures or coerces a woman into becoming pregnant or into continuing or ending a pregnancy against her will. Remember that you deserve to make your own decisions about your body and your future without being made to feel afraid. I have informational materials on reproductive coercion that I can give you and go over with you if you're interested. Right now, I would like to talk to you about forms of birth control that your partner will not be able to feel or tamper with. So I know we went over a lot of information in a short amount of time. I just want to summarize some of the highlights for you. 1, reproductive coercion is the behavior used to pressure or coerce a woman into becoming pregnant or into continuing or ending a pregnancy against her will through the use of manipulation, intimidation, threats, and/or actual acts of violence. Women victimized by reproductive coercion may not recognize that these behaviors are abusive, particularly if there is no history of physical or sexual violence in their relationships. The link between intimate partner violence and reproductive coercion likely explains why women who are abused by their intimate partners are at greater risk for sexually transmitted infections and unintended pregnancy. Screening for reproductive coercion in a clinical setting can greatly reduce morbidity and mortality from reproductive and sexual health diseases and IPV. With that, I'd just like to say thank you for joining today. If you're interested in purchasing a hard copy of the Reproductive Coercion Toolkit, you can do so at the Feminist Women's Health Center website. We also have educational materials on reproductive coercion available for download in both English and Spanish. I've included the link to our website right here on this slide, and I've also included my email address, and I would be happy to answer any follow-up questions. Please feel free to email me, and thank you so much.
Great. Well, I'd like to just take this time to open it up for any questions or comments from the audience. Feel free to type in the chat box, or you can unmute yourself and share your questions or comments. We have a couple people typing in, so we'll wait for those comments.
All right, so Jen Robinson wrote, thank you so much for this information. Do you have a recommendation for screening tools, questions to screen for other forms of intimate partner violence after reproductive coercion has been identified, adolescent specific? That's a very good question. Thank you, Jen. There are materials for screening, particularly for intimate partner violence in adolescents, available on the National Coalition Against Domestic Violence website, the NCADV website, who were participants in the writing of our toolkit. And I know they have a toolkit for screening specifically for intimate partner violence that may be useful for you. And again, it's very important to screen for intimate partner violence after you've positively identified reproductive coercion. And John Helm said, thank you. I will get screening tools at the website and share with our providers. Oh, yay. Thank you, John. Good for you.
And you mentioned that the hard copy is available for purchase, but folks can use the downloadable version for free. Is that correct?
Absolutely. We've made the downloadable PDF available for free on the Feminist Women's Health Center website and the National Coalition Against Domestic Violence website and the National Organization of Men Against Sexism website. All three organizations are providing the PDF for free download, so you can share it with whomever you like. And again, we have informational materials on reproductive coercion. Specifically, we have brochures, again, in English and in Spanish for your waiting rooms and your exam rooms that are also free for download on all three websites. And again, if you wanted to have nice, shiny, glossy versions of the toolkit printed out for any particular reason, we have that service available on the Feminist Women's Health Center website as well.
Are there any other questions or thoughts from folks?
I have a question. So thinking about kind of the intervention piece and adolescence, and I think in the way that some of our school-based health centers in particular have addressed some of these issues is through, using some group work, especially around just kind of the issue of potential inter-partner violence. Maybe it's not happening to them, but kind of awareness. What are your thoughts on that as maybe not a tool for intervention or a tool for intervention in the... Yeah, go ahead.
I was going to say, sorry to speak over you. I was going to say that's a great point. And awareness raising is very important, particularly among adolescent girls who we do feel are perhaps at an increased risk of experiencing reproductive coercion. In the toolkit, there are some great awareness raising fact sheets that and a self-quiz, which we really like, that help women identify whether they're experiencing reproductive coercion and are unaware of it. But on the awareness raising materials in the toolkit, we specifically say that these materials can help you not only recognize these behaviors in your own relationships, but in your friends and family's relationships as well, and help you share this information with them so that they can identify whether their relationship is healthy or whether they're experiencing abusive behaviors that they shouldn't have to. So completely agree that awareness raising in general is important, because sharing of information between young women can really help others understand what's going on in their relationship and identify their own relationships as unhealthy.
I know you spoke earlier that this is really geared towards women, and I'm wondering also, is there any kind of awareness raising or strategies that you have used to engage men around this topic?
That's a really good question. And of course, reproductive coercion can occur in both directions. There are women who could be coercing their male partner into having a child against his will, by claiming that they're using birth control and then not, or sabotaging their own birth control, poking holes in condoms, things like that. So of course the behavior can go both ways. However, the reason we've specifically focused on reproductive coercion in the direction of a man using reproductive coercion against a woman is because women are the ones who are going to be affected by pregnancy, and whichever direction reproductive coercion is occurring, women are going to be the ones who are carrying the baby, and therefore they're going to be the ones who incur the reproductive health outcomes of reproductive coercion. And because this toolkit was specifically designed for reproductive health clinicians, that was why we focused on reproductive coercion in the direction of male to female. Because again, reproductive coercion in that direction is a reproductive health issue, and in the other direction is not necessarily a reproductive health issue.